Hi, this is Sherry from the CGH Health Foundation. Welcome to our weekly Facebook Live program. This week's program is part of our Growing Healthier series, and I'll be turning it over to Dr. Kuhns shortly, who's going to be pinch hitting for Dr. Bird this week. And he's going to be answering some COVID questions at the beginning. And so if you have any questions, you might want to go ahead and put them in the chat section. And then when he's finished talking about COVID, he'll be talking to Vanessa Simonton and Amy Kutz from our CGH OB department. August is National Breastfeeding Month, so we've invited Vanessa and Amy to come and talk to us about breastfeeding classes and the other pre- and postnatal classes we offer here at CGH. They're also going to tell us what it means to be designated as a baby-friendly hospital. The CGH Health Foundation is also providing some additional support to new moms. During the COVID pandemic, we noticed that many new moms were struggling with mental health issues. And so we are going to help. Some of the funds that we collect during this year's campaign are going to be designated and devoted to an additional day of counseling with our Ways to Wellness program. And that's a free service that we provide for patients. And that's just one of the ways that the CGH Health Foundation is fulfilling its mission of providing healthier lives for people of the Sauk Valley. And for more information about the Ways to Wellness program, you can contact Christine Romsberg at the clinic number. Her extension is 1916. With that being said, I will now turn it over to Dr. Kuhns.
Hi there. Thanks for bringing me on. Dr. Bird is out of town, so I get to pinch hit here. And So we're going to try and cover a lot of ground about a lot of common questions I've been getting, and then we'll answer questions as they come up. So first, I think Matt's got some stuff about our local rates. So the interesting thing I see here is that old people are really doing well. Younger people are really the ones that we're seeing a lot more of, and cases have gone up. This week, we're seeing a little bit of flattening from the week before, which is good. The 2-week over 2-week data, which you see on the bottom left there, still shows that the general trend is significantly up. But we're not doing terribly here. But our 2-week vacation from having COVID patients in the hospital is definitely over. I admitted a couple people last weekend, and there been a few other people in and out of the hospital. Again, we're typically seeing younger people, and that generally bodes better for their prognosis. But Delta does seem to bind better. Delta's got a better spike protein, makes for higher viral loads, and that tends to get younger people more sick. Even though younger people have less of the little ACE2 thing that it binds to, because Delta is very good at that, it makes higher viral loads, and it tends to get younger people more sick. So. All right, moving on. The case report, we can see we had 14 yesterday. Our positivity rate's 4.6%. Those are, and you can see on the right there, we're generally up a little bit, but not to where we were at the previous surges. Hopefully, we'll stay there and get better over time, and won't follow Florida, Louisiana, that area. All right. So one of the first big things I wanted to talk about is a little bit of a concern over masks. I don't really want to get into the rules and politics of that. They're their own thing. But medically speaking, I do hear a lot of people concerned about them or their kids with masks on. Particularly, there's some videos that measure CO2 behind the mask, and they're worried about rebreathing CO2. So I wanted to make a point with regards to this. Matt brought up this nice graphic there. You can see the lungs, the airway going up above that, the sinuses, and the mouth. When we breathe air out of the lungs, not all the air gets all the way out of the mouth, and some of it stays in the airways and the sinuses. And when we breathe in again, we rebreathe that air, and that air has more carbon dioxide in it, but that's normal. If you add a mask in front of that adds a little bit of room to that dead space. So when we first breathe in, we pull in just a little bit more rebreathed air from behind the mask. But relative to all of that in our sinuses and our airways and all the way down to our lungs, to those small air sacs, it's a pretty small change in the amount of what we call dead space So it's a small percentage change. And once we breathe that in, the rest of it's regular fresh air like the rest. So when you measure carbon dioxide behind the mask, it's higher. But if we measured it in the mouth or in the airways, it would be the same. So that's something that's used to scare people some, I think. And hopefully that helps us understand that better, that what we don't see are changes in blood carbon dioxide levels or changes in physiology. We've all suffered through wearing masks in the hospital here for quite some time, and we've still all done well. So while they're a pain at times and inconvenient, I get it. Medically speaking, not too much worry, and I wanted to dissuade this idea that we're markedly increasing the CO2. Next, there's a lot of talk about immunity, natural immunity, vaccine-induced immunity. It depends a lot on what you're measuring and how long it's been since you've had your infection or vaccination. We do see in both cases antibody levels dropping a little bit over time. Now, that's not the only way your immune system works. Your immune system has memory T cells and B cells, if you've been exposed before, that can ramp up a response. So when you have a reinfection or a breakthrough infection after vaccination, typically if your body's seen this before, because COVID takes some time to get sick, the people that I admitted this last weekend were pretty typical. They got admitted around day number 10 of illness. Because it takes some time, you've got some time to spin up that secondary immune response and get on top of this before it gets bad, if you've seen it before in one way or another. If you haven't, that's when people tend to really get into big trouble. What a booster or another reinfection does is it boosts up those antibody levels to the point that it helps even against Delta. Delta's special sauce is not that antibodies don't bind or don't work to it. It's just that it makes a lot higher viral loads. So there's a lot more to deal with. So you need more antibodies, especially if you're going to head it off right at the gate, so to speak. It's easier for it to get a foothold on an infection up in the nose, but before it gets bad down in the lungs, that can help fight this off. Influenza is very different that way. You get infected with influenza, 24 hours later, you're already sick. So there's not much time to spin up that secondary response, and it's a harder target for vaccination. We had a comment up there from Mary. I'm happy to look at that. I'm wearing my mask. Do you think we're going to have a booster soon? Well, the answer is yes. The CDC is recommending a booster for the general public about 8 months after your last shot. That's based on data out of Israel showing that antibody levels are decreasing enough where at least that initial protection is not as good, and especially in older people. So we want to boost those levels up. Now, that doesn't mean that protection is worthless. Even after 8 months out, if you got it, you'll still be able to spin up that secondary immune response. But, the longer you get, it takes a little longer to do that. You get a little more sick before your immune system is able to kick in that secondary immune response. And we're seeing more breakthroughs. So the answer is yes, we'll be getting boosters starting in high-risk groups sometime in September. Right now, the CDC has also recommended a third shot for immunocompromised people. This is a little different than a booster per se, because immune-compromised people never really got a good enough response from 2 shots. They really need a 3-dose regimen in that case. So if you are immune-compromised now and getting your first mRNA vaccine, you're going to get 3 shots about a month apart. So it's a little different than a booster. It's more that the primary series needs to be 3 shots in that group of people. So those people can start to look to getting that through their local pharmacies or CGH pretty much any time now. So let's see. The myocarditis, that's another big one that people get concerned about, especially when we're talking about kids. The myocarditis is most often seen in young males after their second vaccine. it's important first to understand what myocarditis is. If we break down the Latin, myo is muscle, cardio is heart, and itis is inflammation. So in simple terms, it is an inflammation of the muscle of the heart. We're probably all familiar with getting achy muscles when we get sick with viruses. We just feel, we hurt all over, we're just achy all over. That is a myositis, not necessarily involving the heart, but the virus has inflamed the muscles. We feel achy like that. It gets better with time. And typically myocarditis is also self-limiting, and it's a similar inflammation, just this time in the heart. The myocarditis that we've seen after the second vaccination tends to be pretty mild and self-limited, more so than the myocarditis we see after COVID, but it does happen. It's about 77 per million doses in the highest risk group, that's young males. After COVID, it's about 450 per million for reference, and it often tends to be somewhat more serious. You can minimize that risk a little bit by not by giving your immune system and your body a little bit of a rest right after the second dose. I think we see the most trouble in young athletes, young men probably in particular. That may be part of the reason they're the highest risk group, who just push too hard right after vaccination, and that encourages this inflammation to happen. But in any case, the risk is still pretty rare. It's a lot less than the risk for COVID, and it's almost always self-limiting. It's a cousin of those achiness we get with any virus. So take it easy after the day, especially after your second shot, and realize that that the real risk for myocarditis is risking COVID. And with Delta, unfortunately, being as contagious as chickenpox, it's going to find everybody at some point. So you either take the risk, the 450 per million risk of after having COVID, or the 77 per million in the highest risk group. Again, that's young males. Doesn't mean that young males shouldn't get that at all. It just means that we need to be a little careful with them the day after vaccination in particular. So if we get a Moderna vaccine, do we have to get a Moderna booster? Can we get a Pfizer booster? So the recommendations are that you get a third dose of whatever you got before. That said, there is a caveat in those recommendations that if it's not available or you can't get that, you can swap between. So it is legal, so to speak, to get a Moderna after 2 shots of Pfizer and vice versa, but it's generally recommended if it's available that you stick with the same series. All right, I'm considered immunocompromised, and a booster would be beneficial to get another vaccine in general. So if you've had the mRNA vaccine and you are immunocompromised, you should, if it's been at least 28 days since your last one, you should indeed, yes, get another vaccine of what you got before. The only caveat to that is Johnson & Johnson. Notice we've kind of left that out of this. You will likely need a booster for Johnson & Johnson as well. The reason we don't have recommendations on that yet is Johnson & Johnson is just finishing up their big trial of their 2-dose regimen. It's actually been going on a while. They were testing 1 versus 2 doses for a while. We should have more data on that in a couple of weeks or within a couple of weeks. And at that point, I think the recommendation for Johnson & Johnson will come out then. I suspect it will be a booster. Whether it's necessarily Johnson & Johnson or a different one, we'll have to see what their results are. One issue with the way Johnson & Johnson works, since it uses a virus to get the immunization in, when you give it that same virus a second time, it's a weakened type of cold virus that they use to deliver it, an adenovirus. Your body recognizes that virus because it's seen it before, and it destroys some of that on the way in. So the second dose, some of it is destroyed. That doesn't happen with mRNA vaccines because they're just in a lipid envelope that your body doesn't recognize as a foreign invader and doesn't cause that issue. So it's possible that people who got the Johnson & Johnson may get an mRNA booster, but that we don't know. Hopefully we'll know in a couple of weeks. Can you touch on recommendations, thoughts, opinion when it comes to vaccination and pregnancy? Yes. there was just we finally have a real data and studies on that show that miscarriage rates are not higher with vaccination, which is what we expected, but is good. We wanted to make sure on that is definitely the case. What is definitely different between vaccination and not is how the mother does. We've seen it here where we've had a really bad case of COVID with pregnancy, and pregnancy is considered an independent risk factor for higher risk bad outcomes with COVID. So if you're pregnant because because of the immune changes that happen with pregnancy, you're not able to fight COVID as well, and the risks to mom are significantly higher. And we've unfortunately had to have a patient have an emergency C-section while on the ventilator, which is something we really want to avoid. So all the organizations, the American College of Gynecologists, the Society of Maternal Fetal Medicine, they're very specifically recommending immunization in pregnancy. I know that's a scary thing to think about, but here, what's very clear now is the greater risk is getting COVID. Related to that, and we can talk about breastfeeding, the mRNA vaccines and the Johnson & Johnson don't get into the breast milk, but the antibodies that you make ultimately do and are protective for the baby. And we know that kids under 1 have a little higher risk of bad outcomes with COVID too. Okay, there's a question. Can you touch on the long-term effects of vaccines and how confident you are there wouldn't be risk down the road? Very good question, because this is what a lot of people worry about. I probably should have added it into my commonly asked questions. So thank you for bringing that up. First, it is important to have the caveat as we never know 100% what we don't know. We can balance risks. In this case, we can make a pretty clear assessment of what is likely medically to a pretty high degree of probability for a few reasons. For medications that you take every day for the rest of your life, you can build up effects, you can have drug interactions over time, things can show up more often down the road. For injections in general and vaccination specifically, in 200 years of vaccination and variolation, the precursor to vaccination, what we have seen is the side effects that happen and the problems that happen with the vaccines, they happen within the first 8 weeks. Sometimes they could be long-term if they happen, but they first occur within the first 8 weeks. So in order to be reassured about whether a vaccine is safe, we need a lot of first 8 weeks data. In other words, a lot of people that have been through that first 8 weeks. We have now billions of doses in, and we've really accelerated that process. For the HPV vaccine and some of the other ones where we were only giving it to a small slice of the population, it took many years to get that much data, that many people through the first 8 weeks to know where we're at. So in this case, we've really brought that all forward by vaccinating so many people that we can be very confident that we've had a very good look at the first 8 weeks. Things that are very rare, these so many per million side effects that are very rare and hard to find until you get to a lot of people. We now know them. We know who they apply to and how to address that. So the risk that something is going to come up over the long term seems extremely remote at this point. And the counterbalance to that is if you don't take that little bit of unknown that's left and you decide I'm just going to do nothing, Delta is almost certainly going to get you. Remember, this is as contagious as chickenpox, and in terms of long-term side effects, we're already seeing a lot of long-term side effects from COVID, long COVID, more prolonged myocarditis, people with chronically damaged lungs. And the other unknown with COVID, which we don't know either one way or the other, but there's precedent for this, is whether it's going to cause some sneaky problem down the road. And we do see that with viruses. Chickenpox, it sticks around, that virus sticks around, and decades later comes out as shingles. It's the very same virus that you were infected with as a kid. You didn't get shingles from somebody else. You got it from the same virus that's been hiding out. Hepatitis C, you get that in your young adventurous days as a young adult most often, and that sits there and smolders for decades and causes liver cancer years down the road. Human papillomavirus, you also get it again when you're young and sexually active, and then the average is 23 years between infection and when the cancer starts. So it's not unusual for viruses to cause stuff down the road. We don't know what COVID is going to do that way, but there's certainly precedent for that. And that, to me, is the much bigger concern than the vaccine, which doesn't stick around. I mean, mRNA is gone very quickly. Your body disposes of mRNA all the time. And what's left is your body's memory of what a spike protein looks like. Also, the spike proteins that you manufacture are only around for a very short time. Your body keeps refining its immune response over the first few weeks, which is why autoimmune reactions can happen a few weeks later. But beyond a few weeks, everything's done. And I wouldn't expect to see anything else come up that way as far as a dread long-term side effect that has any comparison to the risk of risking COVID. Next question, which vaccine has the least risk of complications with respect to heart inflammation? My FAA aviation medical examiner is advising against getting the vaccination because there's been talk about regional aeromedical surgeons with the long-term effects of the vaccine in airmen. I've been flying throughout the entire pandemic with no vaccine. It seems like a pick your poison type of a decision. Yeah. So I've heard this from other pilots too. So thank you for bringing that up. And I recently had a pilot that I know well also not get vaccinated for this and end up with COVID. And that's what you really don't want to have happen, because remember, the statistics are myocarditis after COVID is 450 per million. And typically that myocarditis is more severe, more longer term. We really haven't seen much in the way of myocarditis in adult people. This seems to be more limited to young males. So I don't know what your age is or what your situation is. But to answer your question specifically, the one that this has not been seen in much is the Johnson & Johnson. Johnson & Johnson has the risk of blood clots in young women, but that's also a very specific thing. These are not the typical type of blood clots where your platelets get sticky and bind together to make a scab. Those blood clots are very unique in that they're antibodies that bind platelets together and kind of make a clump of antibodies and platelets that clogs things up. And they're very rare, but they're typically seen in people who are at risk for autoimmune disease, which typically tends to be young women. So if you're not a young woman, you don't have autoimmune disease, rheumatoid arthritis, type 1 diabetes, not type 2, only type 1 is autoimmune, then you're not particularly at risk for that issue. And that would be the lowest risk for myocarditis from the vaccine. The only potential caveat to that is, remember, Johnson & Johnson is not quite as good. It's not real different, but it's not quite as good at preventing COVID. So to the extent that there's a little more COVID breakthrough after Johnson & Johnson, that might increase your risk of myocarditis. But if if your primary concern in the moment is not getting myocarditis from the vaccine, then Johnson & Johnson's probably the lowest risk that way. All right. Any idea when the vaccine will be available for kids under 12? They've turned in data on that, and I anticipate that it'll be probably within the next month or so that we'll see the next step down. Now, this won't go all the way down to young kids. I think they're looking at like 8 to 12 range in the next step. So that'll be coming soon. And while kids have generally had a lower risk, and that's still the case, that's changed a little bit with Delta because of the higher viral loads and the better binding to the ACE2 protein. And you can see it in Florida, especially when you get really high volumes of Delta in general. You start to see, the way it's a small percentage in raw numbers, a lot of kids start to end up in hospitals and in trouble as well. So it's coming fairly soon. I don't have a date for you, unfortunately. Any other questions? All right. So we'll answer any more COVID questions at the end. We need to move to a pivot to a much more pleasant topic here. We're going to talk about babies, specifically breastfeeding in babies. And we have two of our experts that have taken special postgraduate training to be the experts in that and have a lot of experience. So we're going to bring on Amy and Vanessa here, or Amy and Marcela, I'm sorry. All right. You guys can answer this, whoever wants to. One of the first is, what benefits does breastfeeding bring in general? Let's start there.
All right. If we would sit here, and I talk about this a lot, if we would sit here and just talk about the benefits of breastfeeding, we'd be here all week. But we did highlight a couple of them just to kind of talk about it. For baby, we all talk about this immunity. Everyone knows about the immunity breast milk brings. But I just want to highlight that the immunity is that while you're breastfeeding forever, as long as you breastfeed, you are providing immunities to your baby. So whether it's 6 months, 2 months, 2 weeks, 3 years, you're providing immunities that whole time to your baby while you breastfeed.
Yeah, and that includes, to an extent, even COVID protection. The antibodies from the vaccine or previous natural infection, they get in and they protect babies too.
Yes, and these babies with immunities are sick less often. While breastfeeding, you have protective features against SIDS, and as your baby grows, your breast milk will change to meet that baby's needs at that time. So a 1 month old baby's milk is different from a 2-year-old baby milk, and it just continues to grow. So those are the benefits for baby. I'll give you benefits for mom.
For mom,
Yeah.
It's obviously free. It's convenient. It's easy to make milk in general. Breastfeeding promotes weight loss in the mom, and it
That's popular.
Yeah, that's a good selling point. And it reduces the risk of bleeding postpartum and reduces postpartum depression, as well as a million other amazing benefits.
Yes.
Yep. So what are some of the misconceptions? I mean, there's some people they're worried about, my breasts aren't clean enough, or, I'm worried that, I don't eat well enough, and those sort of things. What are some of the other misconceptions that people have about breastfeeding?
Well, the number one thing that we receive a lot is that, well, my milk dried out. I didn't have enough milk. And it's everyone's worry that there's not enough milk. I think the number one thing is to take a class. The more you know about breastfeeding, the more your success rate goes up tremendously. So it's having support, knowing the basics, and really does help.
Yeah, and you guys are fantastic with support. I mean, I've had patients that they call you guys up at 2:00 on Sunday morning, and there's always somebody on the OB floor who will lend a hand and will get you set up with the real experts very quickly. So if you're struggling, if you're having pain, any of those sort of things, boy, we just got to reach out to you guys. You guys are awesome. And my patients who have reached out to you guys have been so thrilled and really fixed a lot of problems. There are a lot of things that people give up on awfully quickly, but with education and nipple shields and other, tools and tricks, you guys make it work.
Yes. With that, we do offer a lot of support. We have free classes, CGH. We offer free classes for anyone that wants to take a class. And usually my highlight is on that. If you want to breastfeed, take a free class. If it's not my class, I will not be offended as long as you take a class. We offer free lactation services. And typically I like to tell everyone breastfeeding does normally go beautifully, but if it doesn't, they wouldn't give us fancy initials behind our names if it didn't always just go perfectly. And our department's actually full of lactation people. We have 2 consultants. We have 2 people on day shift that are specialists, 2 people on night shift. So that's why if you do have a question, just a basic question, all our nurses are trained on just the basics of breastfeeding, so we can help and support everyone as much as we can.
That's awesome. All right. So what does baby friendly mean? Is that just a slogan? We're baby friendly?
Yeah, we decided to start being nicer to babies. I'm just kidding.
Yeah, the bad old days. Yeah.
Yeah.
No.
Baby Friendly is a certification that we got here at CGH, and it's 10 different steps that we took and put different protocols in place to help women successfully be able to breastfeed. We recognize that in the first couple days of life, it's very important to get baby off to a good start breastfeeding, and that will help you in your breastfeeding future.
So it was like the first step that we needed to get us as much support as we can for breastfeeding. Everything that we do here in the hospital actually sets you up for the rest of your breastfeeding career, and we recognize that, and all our nurses are excited to help anyone that needs help in breastfeeding.
Yeah, and by certification, we didn't just fill out a form. I mean,
Oh, no.
there was an actual process, and people check things out, and yeah, I remember that being pretty involved. So awesome.
Years in the making.
So if people want to get a hold of you, they can just call the hospital number and ask for the OB floor, and somebody will find you?
Yes. For any questions, we're obviously open during any pandemic, holiday, weekends, anything. You can call any of the nurses for basic questions. And if it's something that they think is a little more advanced, then they schedule you guys in with us.
Awesome. We want healthy babies. We need some good news in all of this, and nothing better than healthy babies. So awesome. All right. You guys have anything else you want to add?
Questions? We're up for questions.
Okay. Well, we'll save the COVID stuff for a little bit, and we'll get back to that. But any other questions on breastfeeding and babies?
Yeah, it is breastfeeding month, so all my ladies that have breastfed, show your strength and being proud, and I always like people to bring out that they have, just so they can support people that are new to it.
Right. Okay.
Awesome.
All right. So, seeing we got no questions on breastfeeding, they'll have to call you up on your own time sometime, I guess, when they think about them. But thank you guys so much for what you do and for coming on. Great asset to new moms.
Perfect.
And have you guys certified and on board. Thanks. Okay. So, we'll get back to we had a COVID question there. I'm really nervous. This is more of a statement. I'm really nervous to give the vaccine to my children that are 7 and 11. Yeah, I mean, it's a tough thing to put, it's a mom thing, right? We don't want to put needles in arms. I get that. And we certainly wish that none of this happened to begin with, but we're kind of stuck where we're at. And, I've got a 16-year-old and a 19-year-old daughter, and it definitely took me some time, because they're pretty low risk, to get comfortable that the risk of the vaccine was low enough over time that they should get the vaccine. So they have now, but that took me a while to get comfortable with as well. And this is all I do. I mean, it's my job in many levels to keep abreast of this. But it is very clear to me that the risk of doing nothing is greater by a significant margin than the risk of doing something. And we're going to take this step by step. We'll take it down one. Your 7-year-old may be a while before it's approved, and they'll take a close look at that age group to make sure the benefits continue to outweigh the risks. And if they don't, then things will wait or get reformulated or not happen at all. The 11-year-old is probably coming pretty soon. And we know the risks for COVID, while they're less in kids in general, they get higher as kids get towards their teenage years. So there is a progression there. So, okay. If I have a severe reaction to the first vaccine and couldn't get the second only have a half a spleen. Any recommendations? Okay, well, this is pretty specific. The first thing is definitely talk to your own doctor. Maybe you already have. Any recommendations? Well, the first dose gives you some protection, but if unfortunately against Delta, it's not great. The first dose was 80% or so. Depending on how long it's been, that number is quite a bit less when it comes to Delta. So you got to be especially careful. There is a way to check antibody levels. Antibody levels aren't the only way that we're protected, but it's one thing we can measure and give us some idea of how well you've responded. There is what we call a semi-quantitative spike protein antibody level that looks at the antibody levels you develop to the spike protein from the vaccine. Your doctor would have to do a little bit of digging to interpret that because there aren't national standards for what they mean, but there is some primary data out there saying what the average antibody levels are after natural infection, average antibody levels after vaccination, and you can make some sort of inference as to what how your levels fit into that. So that might be an option. You might ask, if you can't get one vaccine, if there is a different one that you might be able to get. Again, this is stepping out of typical guidelines and definitely would involve your own doctor in that situation. But those are some thoughts. And looks like we're running low on questions. So let me make sure I've got everything that I wanted to cover. And yeah, oh, wow. There is one little last thing. We talk about natural infection versus immunization. You can make arguments on both sides of that are fairly reasonable. And it's close enough in some ways that I think that arguing the difference is splitting hairs a bit. But what's clear is the best immunity, the best antibody levels, the best protection come when you combine previous infection with vaccination. It's better than a full course of vaccination, and it's certainly better than natural immunity alone. So you certainly have the opportunity to get the best protection. And having seen what I've seen, and having had COVID myself, unfortunately, I want the best protection. So I got vaccinated after I had COVID. A little higher rate of aches, pains, and fevers the day after, but it was pretty minimal. And I'm certainly glad to have the best protection possible at this point. Okay. How are we able to know in our area or anywhere for that matter that it's the Delta variant? Okay. So yeah, this is a good point because we don't get individual results. If I send your swab in, I don't get a result that says it's Alpha, it's Delta, it's Gamma. What we do get is the each state will take 5 or 10% or a certain percentage of the samples after they've been de-identified and do all the genetic sequencing to know what's in what area. So we get reports that certain numbers of percentages of COVID are one variant versus the other. Right now, it's in the mid to high 90s that it's Delta pretty much throughout the U.S. So we're bringing up the spread there. So that graph is looking at the samples that went the extra step and were genetically sequenced to see what it is. So the Delta variant is dominating. It's much more effective because of the higher viral loads it can do. It's much more competitive, and everywhere Delta's been, it's just run over all the other variants, and it's just much more successful, outcompetes them. So if you've got COVID, even in this area, it's almost certainly Delta variant to a pretty high degree of certainty. But good question. All right. Thanks for all your work. Thank you. It's what we do. And we're pretty proud of how CGH has done with the vaccination clinics and trying to make things as easy as can be. But it's been a very, very much a team effort here. So I'll take that for everybody here. All right, I think that's it for questions. So thanks again for your time. Oh, all right. So I'm confused about last night. They said 8 months, but now you're saying it's 4 weeks for severely immunocompromised people. Yes. So that's depends on who we're talking about. So for the average person, if you have a normal, healthy immune system, and by that you can assume that you're getting a good response, then it's 8 months, because it takes a long time for those antibodies to drift down. And again, it's not that you won't have any protection after that, but your protection against more minor breakthrough starts to wane. Still have pretty good protection against severe disease, getting intubated, hospitalized or dead. But we can make the protection better against any level of infection with a booster. Now, when we're talking about 4 weeks, we're talking about specifically the immunocompromised population, the people who've had a solid organ transplant, they're on immunosuppressive medications, they're on chemotherapy, stuff like that. For those people, they need 3 shots, no matter how long it's been, so long as you've met that minimum interval of 28 days since your second shot. So that's the difference. In the immunocompromised people, they're going to get 3 shots about a month apart. If they had the 2 a while back, then they're going to get a third one. If they're starting now, they'll go through a series of 3. And for the general population, we're waiting about 8 months before you consider a booster shot. Hopefully that answers that question. They seem to be trickling in, but I think we're good. Okay, thanks again. We've run a little bit over. Thanks for everybody's patience and time. And take care out there. Stay safe.